welcome to our very first inaugural episode of the Future in Health podcast series. This series has been in the making for over a year, where we thought a lot about all the things that we wanted to talk about when it comes to how providers, payers adopt digital health solutions, how we can get digital health solutions in the hands of our patients who really need it. And we've taken a lot of different forms in mind. We do a in-person session 4 times a year. We do a lot of webinars. We have a lot of offline conversations. And over the years, we've thought about this format as something that we can sort of bring people along and have slightly more relaxed and slightly longer form conversations to be able to bring these insights from the field to you from the people who actually experience it on a day-to-day basis. I'm very excited to introduce our first speaker of this inaugural podcast. Ashish is a brilliant mind, is a lifelong digital health evangelist, and above all, a great friend. He has inspired thousands of people into a career in digital health. He has taken really difficult digital health concepts and made them much easier. And he has worked on the entire life cycle of developing these tools, getting these tools implemented, keep working in the trenches to get these in the hands of patients, and is a tireless advocate for how digital health is going to improve the world. Today, I'm going to talk to him about AI and generative AI. He recently wrote a Substack that I have linked to in the description of the podcast. That is a really good read. And what I'm going to do today is I'm going to follow up on that and have a conversation about him, especially focusing on things that he wasn't able to write because he ran out of words. But hopefully he'll share that with us. So with that, I'd like to welcome Ashish Atreja. Welcome, Ashish.
It's so good to be here. Thanks so much for having me. It's a pleasure.
Wonderful. So Ashish, you're as I was saying to the audience, you have had an illustrious career in digital health and getting digital health adopted by the masses. I want to ask you, what has been the hardest part of your job so far?
It's very interesting. I think there is an evolution in terms of society and health systems and healthcare organization adoption and perception of digital health. I started off in 2012 when I moved to Mount Sinai, the first app lab, the digital health at that time. It was 2 years after iPad came. At that time, people didn't know what digital health is, right? So we had to do a lot more conversation of what it is. So the definitions of digital health, what it can do, it includes apps, includes text. Those kind of conversations happen. So just more about what it is. I think now we are beyond that stage where people say it's real. And the question comes, how to really make it valuable? So I feel the conversation has shifted from what we call as a fit journey, from innovation, what it is, to actually transformation. How can we leverage it in a most scalable manner? And what we call at UC Davis Health here, no patient, no researcher, no clinician, no community gets left behind.
That's awesome. That's a really good way to frame a mission. So let's get into generative AI. There's been obviously a huge amount of hype behind it, and in your Substack, you actually talk a little bit about the Gartner hype cycle, right? So when I'm seeing the world sort of really go into the Gen AI direction, where everyone's like, Gen AI is going to solve all of our problems, you've taken a different perspective on it, and you've said, people, hold on, not yet, right? And we're going to go through a different kind of cycle before AI becomes, really scalable or accepted in our systems. I want to hear more about that. Tell us about your perspective with Gen AI, where we are today, and where you think the next few years are going to go.
Yeah. So first of all, I'm a big believer in generative AI and its potential. I feel it's the first time we have witnessed the kind of creativity that can happen from artificial intelligence that have, so far we've never seen before. At the same time, talking about the same innovation to transformation journey, which we have seen in digital health, I would say we have seen in electronic health records, right? We felt patient medical records will be mainstream when I was doing my informatics fellowship at Cleveland Clinic by 2005. And it took 15, 20 years, and still not it's mainstream. So what we felt is we tend to look at innovation and we say, oh, this is possible. But when a new technology comes, we have not embedded that technology into our day-to-day workflow, into our governance, into our privacy, security, including our evidence that can we trust, and if we can trust, what part we can trust before we use it for, life-threatening things, for example, a life-threatening decision. So as we try to uncouple those things or kind of tease those things, the journey becomes much more longer. So what I wrote in the Substack article was we are in the hype peak of generative AI because people are testing it and they can say, oh, I can do this. But typically what happens in these technologies when they come is as soon as you start doing it, you start seeing hallucinations, security, all these other challenges, the cost, humongous cost to it, right? So people just get disillusioned because there's such a big hype and you can't immediately create value from it. There is a death or valley of disillusionment that happens. And what is very interesting is typically in many technologies, after this disillusionment that happens, and that's like countless hours, inefficiency, many startups going bankrupt, many health systems finally giving it up. This is not the one. Physicians again getting disillusioned with electronic health record equivalent technology. Then people slowly start figuring it out. And then you start creating what I call as a true peak, which is the transformation peak, not the hype peak. And the true peak happens is much more real. It happens a little slowly, but it is also that creates the maximum value and is also sustainable. So one of the things is here's some of the strategies we're going to be talking. How can we go from hype that's there and use that momentum, but create a framework which binds it to real reality? And so our trough of disillusionment doesn't happen that much, and we are able to smoothen that to actually the second bigger way, and how to make it happen with a lot of intent rather than happening without intent on its own.
You talk about the momentum that you're seeing in terms of the hype that AI is creating or Gen AI is creating today, and that's creating a little bit of momentum. Do you have any examples of sort of maybe even within your own organization at UC Davis Health, where might be this hype being represented in your organization? Is your leadership coming and saying, Ashish, we need Gen AI? Are your physicians from the front line, are they coming and asking for it? Or is it just crickets? Like no one's talking about it, no one could care less. What's the general sentiment of where you're at and how you're seeing this hype?
It's everywhere. I would say the typical example is medical students are coming to me and they say, we're building this tool. We went online and now we are building this tool. We want to bring it on to UC Davis Health. The startups are going and they're just putting Gen AI. Earlier, they used to put AI in whatever they used to say. Now they've just put Gen AI in the top and started pitching one component, one API to OpenAI, and you become a Gen AI company in that regard. So I think it has become a way to sell. What I love to see is it becomes a way to create value.
That's a really good quote.
Right. So medical students to faculty members, the grants are being written. The good thing in the faculty members grants are they are putting a hypothesis out there. And I think that's what is needed. We need to still use the same scientific principles to say, this is potential. How do we prove the value? What is the framework we use to measure the value? In our case, we are using return on health framework, which is the AMA. And that is not just on the financial value, but can you impact patient experience, physician experience, patient outcomes, and patient safety, and overall efficiency, right? And that leads to multidimensional value in that regard. We are also seeing some very good use cases that are coming across the board, which really will lead to sustainable value creation. What generative AI has done to ambient intelligence. So earlier, so far, whatever technology has touched physicians, it has always led to more time, more effort, and more friction for physicians. Electronic medical records are a good example. We never were in a driving seat for EMR. We never co-designed, co-created the components of EMR. So in a way, many of us felt After getting entire medical school education, we have to relearn even how to take care of a patient because we have to keep on typing and clicking, which is not intuitive at all in many ways to us. Uh, Now, for the first time, I believe we started to see technologies which not only can, through ambient intelligence sensors, record, like the conversation, Kamal, I are having, but it not only just records and put it verbatim. Using generative AI, it can complete my sentences.
Mm-hmm.
It can give the structure to my language. If I say review system negative, it can list all of those things. It can take some of the things which are not meant to be in a clinical note. When you greet a patient, those things are taken out. So I think this is the reason I'm very excited is it really has a potential for the first time to save clinicians time and create value for healthcare. Till now, every technology that comes, it may create value, but it leads to more expense. How
Mm-hmm.
about we are able to reach a point where we can create more value and make healthcare more affordable? I think that's
That's
that's what's
awesome.
really.
Yeah, no, that's a really great way to conceptualize it. So, following up on that thought, then, what are some use cases that you're seeing as maybe some of the first set of use cases that are starting to get a lot of traction, maybe at UC Davis Health, but maybe even across the country? Like, what are some ones that you're saying, I love that that's actually creating real value?
Yeah. So I touched upon the ambient intelligence combined with generative,
Mm-hmm.
yeah, abilities for capturing automatic notes and structuring them. Um,
Mm-hmm.
I normally don't try to predict future,
Mm-hmm.
especially than 5 years. And I'll stick to that I don't want to predict more than 5 years. But maybe I'll predict within 5 years. And I presume this automatic note taking with generative AI capability will be there in majority of the healthcare organizations in United States within 5 years. And if it
Mm-hmm.
is not there, then it has to be a very specific reason
Mm-hmm.
not to be there. But the default would be that has to be there. Residents are not going to go uh, to get themselves faculty member in institutions which don't have this capability. Medical
Mm-hmm.
students go into residency programs which will not have these capabilities. Hopefully, this
Okay.
will translate the value to nurses as well. So it will become
Mm-hmm.
a major career choice and decision choice. So that's, I think, going to be pretty much at the top of the list. Some other capabilities that's going to happen. So this is like physician facing technology. Where I think it can also really shine is a persona
Mm-hmm.
of. I'm a gastroenterologist by background, and I remember for every person I have patient, I have to prescribe colonoscopy. It takes me 5 to 10 minutes explaining what colonoscopy is, how to do it, and then create a program so it can guide the patients. Right. Still, even after that, 1/4 of the patients have poor bowel prep. That's billions dollars lost just in inefficiency, and many patients who have poor bowel prep never come back to do any colon screening.
Mm-hmm.
Generative AI can create tools for education. It can really bring the era of what we have been calling for some time from one to one to many
Mm-hmm.
care, right? So if you really look, Kamal,
Mm-hmm.
over the last modern medicine, 200 years or so, the only way to provide care to a patient has been when physician and patients have been in the same room at the same time to provide
Mm-hmm.
care, whether it's guidance, medicine, surgery, what have you. What telemedicine virtual care did was something amazing. It unlocked the space dimension for providing care. So you don't have to be in the same room. Like we are having a conversation right now, Kamal. We're not in the same room. So we've unlocked the space dimension from our dialogue. Similarly, physicians and clinicians and nurses have been able to unlock the space dimension in providing care through telemedicine. But what
Mm-hmm.
telemedicine did not do, it did not unlock the time dimension. And the time dimension that it takes me virtually the same time to provide care, to
Mm-hmm.
counsel a heart failure patients, to GI patient with inflammatory bowel disease, that is the most precious resource. We do not have enough clinicians in the United States, especially as you look at growing population, much more severity of diseases that are coming down the pike. if we really try to just increase what we are doing by increasing the number of medical students, we're going to see the impact 15 years, 10 years later on. And that will still be linear impact. How many more medical students we can grow, right? And residents and nurses we can grow. But what if we unlock the time dimension from providing care? If when I talk to a patient, a newly diagnosed patient with Crohn's disease, half an hour my time is spent is what to expect, when to warn themselves, how it affects different body, how to eat, what to take. If we can package ourselves in some way, and even if patients forget what I say, there's a way they can query it. And they have always on access 24/7 to ask the questions about Crohn's disease. We have suddenly, my time can be 15 minutes, but they can actually have access to a physician kind of knowledge 24/7, 365. And not only my patients in UC Davis Health can have access to that, if we do it the right way through a collective, we can make it available nationally to any patient with IBD. And if we truly go beyond a national lens to a society lens, a community, and a global lens, if we create something for one disease of patients, we can scale it globally, including Africa, Asia. So suddenly, we're completely addressing the supply and demand problem. There's so much demand, there's not much supply. But we are solving this problem worldwide because any person, any country, any Crohn's disease patient in Africa or Asia may have access to the best physician and its knowledge right through their smartphone or even a voice channel, which has never been possible before because of licensing issues and others. So I think this is completely different dimension of providing care, which is patient-centric, empowering, without any wait list, fraction of cost. And once you do education, empowerment, it leads to better experience, ultimately translates to better outcomes, and everyone wins in that.
Really interesting. I think the vision that you're laying out for a new healthcare under this paradigm seems exciting. So let's hope that that actually plays out. There's another theme that you touch on. You talked about it about 5 minutes ago, but you also touch on it in the Substack, right? And that's a theme about open innovation. You talked about how we did not get a chance to co-create the EMR, and so now, as a consequence, there's a love-hate relationship with it that every physician has, and I can relate to that. But talk a little bit about that. Talk a little bit about what do you mean by open innovation? What do you mean by collaborative transformation? What do these concepts actually mean, and why are these concepts important as we think about healthcare innovation?
Yeah, happy to. And I think open innovation was flouted as a concept by the father of open innovation, Henry Kempsford, who is a professor at University of Berkeley. And I think one of the reasons, driving factors for me coming to UC Davis was I see University of California as a great melting pot where it's not just medical science, but nursing, public health, computer science, biomedical engineering, management science. We get a chance, veterinary science, we get a chance to merge all those things right together and really fundamentally evolve our ecosystem. So Henry Kempsford actually talks about open innovation in a way that in today's distributed knowledge networks, there is no single organization, no single society, or no single community has access to a dominant knowledge base or a dominant skill base. It's all distributed among different organizations, different knowledge base. And the only way to create a real impact at a global, national, or bigger level is to open yourself to knowledge base and skill set that's not just within your organization, that's outside your organization. And by opening yourself, you're letting you to take advantage of all those resources, but you also have to really think of outside organization, what I call as a horizontal extension of yourself. All right. And I'll share an example, and we have a lot of those good examples of open innovation in healthcare. We sometimes don't think about it that way. For example, HL7. There's an informatics team, right? So a lot of those standards, which are from informatics folks, are open standards. They are based on open innovation. It's very much similar to what USB did for devices. Instead of each hardware device, a computer maker having its own standard to plug in peripherals. It came with USB concept as a standard.
Mm-hmm.
With HL7 that came now with Fire and other kind of stuff. If we really extend ourselves to beyond that part, we have national associations. Kamal, you've been part of it, and I've been part of American Gastroenterology Association. I work closely with ACC, American College of Cardiology, AMA, and others. I often tell that when I was in Manhattan at Mount Sinai, there are around 150 gastroenterologists in Manhattan. I never felt I was competing with everyone because I was going to the same organization as them, and I was sharing what I'm learning, and they were sharing what they had learned and researched on. So we had an
Mm-hmm.
amazing ecosystem where we were learning from each other. We were best buddies of each other. We were learning from each other because ultimately, the more we learn, the more we take it back to our patients. And that's
Mm-hmm.
where our ultimate value creation lies. But when it comes to innovation, I'm in this innovation journey for last 15 years. As soon as we hear the word innovation, I feel everyone gets blinders on them. They feel,
Mm-hmm.
oh, innovation, IP, I'm just going to do in my secret lab. And I'm the only one who's going to do it and kind of beat everyone to it and that kind of a stuff. And by doing
Mm-hmm.
that, we suddenly fall behind. Think of it. If all the research in the medical science would happen just siloed way, we never share with each other, the whole concept of foundational building blocks of science gets defeated. We
Mm-hmm.
publish whatever we do in PubMed, in Medline, we share in presentations. And that is a great example. PubMed is the best example of sharing and open collaboration.
Mm-hmm.
So in medical sciences, we have this open innovation and radical collaboration because they're fundamental building blocks and societies and national associations which are there to structure that. We do not
Mm-hmm.
have organizations in innovation or transformation. So we lack this collaborative spirit. So one of the things we are doing, we started this journey with Node Health, the network of digital evidence in health, around 6 years ago, to bring multiple health systems, health plans, pharma together in this journey. And I think now what we are seeing is there's a even bigger need now with generative AI, because generative AI is democratizing. Anyone can create AI algorithm. A
Mm-hmm.
person who's not even trained in data science can get full code of algorithm. Whom do you
That's right.
trust? Trust. We're gonna see more tools now that we can ever digest in our lifetime. We need structure, processes in place which will help us get meaningful value out of it, sift through this thing,
Mm-hmm.
evidence at the center, so we can bring or co-create the most trustworthy way of using, leveraging, transforming with generative AI.
Mm-hmm.
So I think that is the biggest need to help us transform from hype to really the transformation value creation peak.
So you're saying that the only way we win in this game is not to give up the idea of co-developing this as health systems. Let's play a really active role in shaping how Gen AI solutions get developed and how they get implemented and how they get sold to us, even maybe. And let's sort of lead it from the front rather than what happened in the EMR movement, right, where we kind of became followers. So
That's correct.
tell me.
Just to if if we don't, the biggest value of generative AI is democratization and empowerment for everyone. If we
Mhm,
don't use become co-creators, we will ourselves have to blame for what happened with EMRs. This is our opportunity to now be in the driver's seat, healthcare physicians. And by healthcare, I don't mean to say health systems alone. I
mhm,
mean, healthcare organizations of any size, whether from our independent practice to FQHC, to a health system, to a health plan, to startups, to big tech, right? To national associations. Everyone has a role to play now and be co-creative in doing things together. So the solutions that come up are meaningful, relevant, and truly transformational at scale.
and you believe so much in this concept that you're actually putting your personal time and your organization behind a new initiative that is called Valid AI. So tell us more. What is Valid AI, and what are you hoping to accomplish with it?
Yeah, so super excited about Valid AI. And people ask me, is Valid AI a organization? It's a new co, it's a startup. And I say, I don't want to create another friction, another
Mm-hmm.
barrier. So Valid AI is an open innovation program, which anyone in any organization can benefit from. And it just came as at the right time. We felt, how do we bring together, how do we create that structure like American Gastroenterology Association, AMA, which can bring us, bind us all together and allow us to be co-creators in this journey and co-value creation and evidence creation. So, uh, so we thought what we need to do is everyone needs to have a shared vision of where we can go and should go. We need to align externally what's happening with the concept of open innovation, also internally what's
Mm-hmm.
happening with the organization. So the central concept of open
Mm-hmm.
innovation, that alignment. So we need to have a vision, what we can achieve, and then we need to align ourselves externally and internally. So that becomes
Mm-hmm.
VA. We need to continuously learn from each other. Big tech, we need to learn from big tech, all the major things, open source tools. We need to learn from startups. We need to learn from other organizations outside the US as well. So we need to learn, and we also need to bring that learning within our organization, because the democratization doesn't stop with CIOs or chief innovation officers, chief digital
That's right.
officers. There's a very big story about, if you really want to be innovative organization, you have to make every person in that organization innovative, right? So that's truly for transformation as well. So you need to spread learning internally as well, something we are doing with our Digital Davis Leadership Program at UC Davis Health, but we need to do more of that. But then we need to go back as we learn to really take the new and build the new science and publish the new science of implementation science. Because
Mm-hmm.
it's not this technology, whether that is Llama or whether that is, Anthropy or OpenAI. How do we actually connect it? Did we de-identify our records? Is it on synthetic data? Do we use Firebase models? And if we connect it, how do we ultimately bring it through the EMR for decision support to physicians, or connect it to digital operating systems so patients get
Mm-hmm.
benefited? Measure the impact of it. How much processing power, how much cost goes into it? And have we trained it enough that we can trust and we can move from general knowledge to some more prescription? Right? So that all part is implementation science. And core implementation science, many times we don't publish that much. We publish randomized control trial, this versus that in 2 pages.
Mm-hmm.
It's done. But you can say, okay, this technology created this impact, but we never talk about how it created an impact. How many FTEs were needed? How many design thinkers were needed? How many developers were needed? How many researcher clinicians were needed? How many, right? So we do the implementation science. And once we create that a playbook, which is repeatable, replicable, then we
Mm-hmm.
disseminate through forums like this, through abstracts, presentations, publications. So it becomes the science. We want to create collectively through Valid AI the science of generative AI, the science which anyone can take, agnostic of the technology, and make it meaningful, relevant for their physicians, for their patients, for their researchers.
Mm-hmm.
And it should be demystified. If we don't demystify implementation science of generative AI, we have not doing justice to the power of generative AI.
Got it. It's really cool. So Valid AI seems to be sort of an open invitation for anyone to join. Can you sort of articulate, if I'm a health system today, what are my benefits of joining Valid AI? What do I stand to gain?
Yeah. So within the Valid AI program structure, we call it an execution accelerator. So unlike some programs which may just have a learning, our goal is multiple health systems, health plans, pharma and industry can execute on various use cases. So it starts like our first focus, and we'll be having bi-weekly learning sessions, which will ultimately move to bi-weekly execution sessions. So any health system or healthcare organization, health plan, pharma or something, as they join this network, they will be able to see where people want to go, what is the possibility. We will have a prioritization set of use cases that are coming, what we call as no-brainers, that anyone should say, oh my
Mm-hmm.
God, this should be done. And we want to jump into it. We're going to be creating a whole use case library so people can browse use cases, who is leading which use cases, and can volunteer themselves to partner. Either you can
Mm-hmm.
code the use cases, co-innovate, or you can become a validation partner, or you can become a transformation partner where validation has happened and you want to do it at scale. So,
Okay.
so structure, and then we're also embedding that a Gen AI sandbox. So
Mm-hmm.
institutions are working with all major tech vendors. So institutions can say, I don't have capability, I don't have developers right now, but I think we really need to do it. So we will be enabling a cloud-based Gen AI sandboxes to them, which then will give technology or support services so they can plug into their data, de-identified or non-PHI data initially.
Mm-hmm.
That way, if I can do something on my Gen AI sandbox, they can do on their Gen AI sandbox if we align from the right
Yeah.
Firebase structure. They can validate what I'm doing and they can create something and I can validate.
Mm-hmm.
So
Mm-hmm.
this what we're calling is a Gen AI highways for validation in that part. I do believe that will lead to many new ideas or some new things. So we're also creating a startup ecosystem which we can validate their tools, but also
Mm-hmm.
there's new as we may be able to create some entities. So Berkeley Skydeck is in terms of accelerating if there are new ideas, many health organizations can do it together. Instead of
Mm-hmm.
I creating something, some other organization creating on the East Coast, and we're competing with these ideas, we do it collectively to groom them. Then we have very close partnership as part of General Catalyst Health Insurance model. So if we are able to incubate something, then we are kind of creating a space where it actually has a funding impact as well. And we do believe if we take the ideas which have already been vetted by many health systems and healthcare organizations, already
Mm-hmm.
been tested in the box and validated, already created transformation value, and then
Mm-hmm.
launched outside, we are much more likely to make them successful than 1 out of 10 startup companies that today go out and try to do that
Mm-hmm.
after they.
Got it. Can you share any examples of organizations that have already signed up? So, are there any healthcare systems that are part of this mission with you?
Yeah, so we have around 25 plus organizations signed up. It started
Wow.
off with our report. Yes, it's just been amazing. And just in the last 6 weeks or so, we have entire University of California collective behind it. So UC Office of President has signed and endorsed this, and all the UC health systems that include UCLA, UC San Francisco, San Diego, Irvine, Riverside, and UC Davis. But we did not want to keep it West Coast or Silicon Valley heavy. So very happy to say we have all the major regions of US represented, and not just academic organizations like New York Presbyterian, Vanderbilt, Michigan Medicine, Ochsner. We also have larger health integrated networks. We have Cedar Sinai joined in. We have Common Spirit Health. So we have organizations of all size. And really what's exciting is we also have society support. So Node Health is supporting and partnering, as well as Coalition of Healthcare AI, which is one of the largest organizations focusing on AI in general, around 1,200 organizations. So that's also as a partner. We're also very lucky to have global partners now. Sheba from Israel, the largest health system there, which is one of the most innovative organizations, and they have a big ARC network, has signed on as a partner, as well as Amrita University in India, which is the largest health system in India now, getting shaped up. And they have committed with 5 to 10 data scientists to work on this AI sandbox with us.
That's
So it's
wonderful.
just been, we're talking to a few in Canada as well. So it's just been amazing. And these are founding organizations. So we had to cap it at certain states. So we have founding organizations, but we'll be keeping it open for organizations to join later on as well. But at least the founding organizations will start it, give direction to it. We'll create the use case library. We'll start executing. We're also looking very closely at ARPA-H to partner with that.
Mm-hmm.
So we can create one of the largest research collaboratives in generative AI. So
Mm-hmm.
any organization which has researchers can actually leverage this AI sandboxes we are creating for their research and promote that, open up for that. So super excited, just tremendous support that we are getting. And there's a full 3-hour summit at Health where we're bringing all those partners together. We have Moffitt Cancer Center representing cancer and Boston Children representing children's hospitals as well.
That's excellent. Wow. So you've been able to garner a lot of support for this already, which is amazing. Congratulations. And as you said, you were able to pull this up in 6 weeks. So it sounds like there is a commonality of what people are feeling and what health systems are going through and the challenges they're foreseeing. And I think the idea of everyone coming together and learning from each other and developing this together seems to be really exciting. So that's amazing. I know we're at the close of our time together here. If you were to leave our listeners with, just maybe one or two key thoughts or ideas or piece of advice, especially as you're thinking about health systems that might be implementing AI or developers that might be developing AI solutions for health systems, what's a piece of advice you would give them?
I, the main piece of advice I would say is we are not at the end of AI, that we are
Mm-hmm.
close. We know what to do, and our product is completely done. We are just at the start. And the only way, at least I have found, the only way to grow is to be open and not closed. And whether it's becoming part of OpenAI or Valid AI or uh, just partnering with others in any capacity you can, um, the value we are able to create now with the exponential way generative AI is progressing, tomorrow it will be 100x to 1000x
Mm-hmm.
the value we can create. And if we are able to get the right meaningful partners and do it collectively, we can completely change the trajectory of healthcare. But if we don't do it, we will create a problem of plenty for every one of us.
Mm-hmm.
More solutions every day that will come to us that we can trust. And it will be all about fragmentation. It will be all about competition. It will be all about me versus the other thing.
Mm-hmm.
Uh, the opportunity we have with just this amazing way to transform, will lose that opportunity.
So it sounds
So
like there is a real opportunity cost if we don't do this well.
that's correct.
And
And
that's
we are,
great that you've taken leadership on this.
yeah, and we're very committed. I'm very thankful for University of California leadership. And I often say, as a public university, our mission is not just to serve California, but the entire nation, entire world. And can we shape or reshape University of California as University of Collaboration and kind of lead in open innovation in that regard? So really, really excited about partnering and excited about journey ahead and publishing and generating the new science of generative AI.
That's awesome. Well, everyone, that was Ashish Atreja, Chief Digital Officer at UC Davis Health, as well as CIO. So, enough jobs to keep him really busy. But then he decided, oh, I don't have enough work. So I'm going to start a new initiative. But if anyone is interested in sort of joining the Valid AI sort of constellation, please contact Ashish directly. I have some of his contact details in the description below as well. And with that, Ashish, I would really like to thank you for joining us today and having this candid and open conversation. And we congratulate you on your launch for Valid AI, and also, hope that the message of open innovation resonates with others and that we can create a new world for ourselves by being the co-creators and leaders in it rather than followers. Thank you.
Thank you so much, Kamal. It's been a pleasure.
Wonderful. Well, until next week, we will bring in other talented and inspirational health system leaders to have conversations very much like this one. So hope you can join us again. Thank you.